So I think our first session is going to be, Dr. Rehman's going to be our moderator. We have some local and regional experts who are going to be part of the panel. Our first session is going to be Controversies in Timing of Surgical Intervention and Our Current Evidence. Dr. Saqib Rehman from Temple is going to be our moderator. Our panelists are Dr. Irfan Ahmed, Dr. Craig, one of our stalwarts who's been here, who currently does trauma at Abington, and Dr. Rakesh Mashru, another one of our dedicated faculty who's been part of the program for many, many years. Our objectives are interpret current evidence, guiding safe timing of orthosurgical intervention in trauma patients, and to damage control and related concepts in 2019. Saqib?
Great, thanks. All right, so this will be a 1-hour session. We'll get through as many cases and slides as we can, and then we'll try to keep moving to the next session. So thanks, guys, for being here. So I'll just kind of make an introduction. Rakesh here is at Cooper. It's a level 1 trauma center, one of the regional centers in Jersey, does ortho trauma like I do. Irfan Ahmed is at Newark University Hospital, so the other regional trauma center in Jersey, from North Jersey. Dr. Ahmed's a hand surgeon, so he's involved in a lot of care for the stuff that me and Rakesh see, but he sometimes is really he's the hand guy in upper extremity, so he does a lot of the upper extremity trauma. And Matt Craig is orthopedic trauma surgeon, kind of more like me, and Rakesh, who's up at Abington, which is busy level 2 trauma. So I think we all have a slightly different perspective. I'm here, in North Philly. I see a lot of gunshot injuries. Rakesh sees a lot of sort of major high energy trauma, and Irfan and Matt see a little bit different stuff than us, I think. So with that, these are my disclosures. They are in the program. Hopefully they don't adversely affect the session. These are the objectives. So hopefully you're all going to get familiar with current evidence guiding safe timing of orthopedic surgical intervention in trauma patients, and see if we can possibly understand these concepts of damage control and related issues, and where the pendulum stands now. So here's a case just to get things started. And these cases, there's a lot of info, and there's gonna be a little audience response, so I know it may be hard to process everything, but this is like a typical OITE question. You may see all this stuff coming at you, and you have to make a decision. So, and this is like a real case. So 32-year-old male, motor vehicle crash, right type 3A open femur. He also has a pretty bad operative distal radius fracture. He's got some chest injury, he's got a head injury, he's got some facial injuries, abdominal injuries, so he's got everything. But he's got an open femur. So I'll just come back right here for a second, because I'm gonna ask you guys what's your next step, okay? So I'll just let you take a second to look at that, the audience, and then I'm gonna come back to the audience response, and you're gonna tell me what's your next step for this guy. So go ahead, let's count it down. What's our countdown? 10 seconds, okay. So go ahead, click in your responses. We'll see what you think, and then we'll let the panelists see what they think. So it seems like most people want to do an ED washout, traction, OR tomorrow. Some people want to do an urgent operative IND and X-fix. Maybe I'll just ask Rakesh here, what might make you do 4? Seems like a lot of people want to do 4.
I think, ED washout is fine. As a provisional thing. If you're just going to get something done, assuming the patient is just so unstable that, is basically.
Patient's hemodynamically stable.
Hemodynamically stable.
Yes.
ED washout is fine, but I wouldn't substitute an ED washout for an actual operative debridement.
Okay.
And the OR tomorrow part of it, we would probably do something that night.
Okay. Would anybody do number 4 on the panel?
I guess it defines, what do you mean by tomorrow and the time of day?
So it's 6 p.m. This guy comes in at 6 p.m.
I don't think I'd commit to a definitive treatment that night. And I also try to look at these questions, you mentioned the diverse audience. What I would do and what I would ask somebody else to do if they're gonna hand me the case, kind of two different things. Yeah, maybe if I was up for fixing it, okay, I'll fix it, but I own it, I'll take care of the problem, I'll take care of the non-union or the infection if that's the deal. But if somebody's going to hand the sale off to me, I don't mind if they just,
You wouldn't ask them to do 2? Seems like a lot of people wanted 2.
yeah, two's okay.
Your partner, you wouldn't say,
but-
hey,
but
can you do that?
If you don't have to bust on the hand surgeons, if you're a hand surgeon, you're not feel comfortable putting an X-fix on a femur because you haven't done that in a while, that's okay. But I have
Okay.
no problem with just washing out, putting
So we have some
traction.
trust issues, all right.
Well, I'll admit to it, but
It's a
if we're
reality.
washing
I
out, putting
mean-
traction, I'm good.
I would err with Rakesh here. So that's what was done here for this case. I honestly couldn't tell you exactly what time of the day it was or anything. I don't remember how bad the head injury was. I do think the patient was hemodynamically stable. I don't know. What I've seen is we usually don't get a red light from neurosurgery to do a washout that, or I should say a debridement that really needs to be done. Because I think my experience is they usually just don't want you there for too long. So if you're saying like, we're going to be less than an hour, I usually find that they're okay with that. But let's move ahead. Lactates.
And that's my point for the traction. People can muck around for a long damn time putting on X-Fix. So
Correct.
if you can do it
Yes.
quickly, fine.
So, I mean,
Yes.
that's a good point, actually. I mean, you hear people say all the time, well, I can do a retrograde
Well-
femoral nail quicker than putting on an X-fix. I mean, and you have to be careful with statements like that. I mean, that may or may not be true, but, putting a retrograde femoral nail or an antegrade nail, whatever, in this case, again, this is a perfect damage control case. So I think, even though you may be facile in putting nails in very quickly, there's nothing, you can never be faulted for putting an X-fix. You can be faulted for putting a nail in and then something bad happens.
And I think there's some evidence to suggest that traction versus X-Fix, traction was fine. But
Yes.
That is
yes,
true.
There is.
Since you're
And I
correct, Tom.
believe that came from Dr. Bossi's center, who's going to be here today. So if that comes up, we can certainly ask him about it out of Carolina's Medical Center. So that patient got it, it was an open fracture. I'll remind you, this was a 3A open fracture. So got a debridement, X-fix. Patient desaturated overnight after repositioning. Vent settings were changed to assist control, SATs in the 90s, lactates 1.7. So hospital day 1, lactates 1.7. Irfan, I don't even know what to make of this vent settings thing. You did surgery, general surgery for 3 years. Like, what does this mean? What's going on here?
I think that's a very basic thing with AC. You have to look at a lot more of the parameters. AC means assist control. That means the ventilator will breathe for you unless you take a breath on your own. It'll help you. But if you're not taking any breaths, then it will do the work for you. But I think the more important things to know is one, what the SATs are. Two, what FiO2 are they getting? What peak pressure are they using? So if you're using a lot of pressure to keep the lungs ventilated, then yes, then that patient isn't stable. So I don't know if just AC is something you can rely on. I think SATs in the 90s is more important. Lactate is trending down, so in that part looks okay. Hemoglobin 7.1, well, he's 35 and it doesn't seem his cardiac-wise, I don't know if all the information's there or not, but I think the SATs in the 90s is probably the most important thing to look
So-
at this. And you already have an X-fix on.
Right.
Initially, I was going to say that's two separate things. Open fracture debridement versus X-fix for a femur fracture. I think you can look at it two different ways. Do you need to wash it out because it's open, or do you need to X-fix it because making the femur stable is better for pulmonary and preventing ARDS? But I think the SATs in the 90s are the most worrying.
So
thing.
how much are you guys involving, to what extent are you completely relying on, so the SICU says this patient's not okay for the OR. Let's say SICU said patient's okay for the OR. I mean, how do you guys weigh the input from your trauma consultants, and how much do you feel, how often are you disagreeing with them? I'll start maybe with Matt.
Maybe less than half the time, but it's not zero. So I guess the fortunate thing now is that it used to be like you admitted the patient, that was your patient, and then that one doctor took care of the patient. Now they have this more of a cycle every 24 hours. So one day the guy says they're not cleared, and the next day they're cleared. What just happened? Not really, nothing changed, but the guy's comfort level or lack of interest in caring for the patient maybe changed. So yeah, I do involve them, but I try to look at the whole situation, understand what's going on. With this patient, it's one of those damage control. You have to wait maybe 5 days. I mean,
What do
day
you think,
one, I think it'd be
Irfan?
too soon.
What about you? Are you finding yourself agreeing, disagreeing with them? Are you having to sort of say, wait a second, I don't like the SATs and the lactate, well, how are you clearing this guy?
Well,
Does that happen a lot to you?
no, I think that unfortunately the pendulum is swinging a little bit where we're relying too much on SICU and the trauma guys, the gen surg trauma, the ICU attendings. And if someone says they're not stable, I'm like, all right, I guess they're saying they're not stable because the thought of fighting and going to the OR after somebody has said or documented that the patient's not stable and then something happens, you're worried about that. So I think you tend to back away a little bit. We do have combined conferences with our trauma team, and I think they are familiar with the concept of early stabilization, but I think we are backing away more than I would probably like.
Yeah,
Rakesh?
I would probably, yeah, I agree with Irfan. I think, it's unusual that we would trump the, trauma surgeon and say, no, you're wrong, we're taking this patient to the OR. And in fact, I can't really think of a situation where that would happen. Having said that, though, we have a similar setup now, at least in place, where, every morning we actually do have an attending discussion about all the trauma patients who are on the board for that day. And, if there's one or two that's not, quote unquote, stable for the OR, there is a discussion why. But usually we do defer to our general surgery colleagues. And unless it's something that, it's just so egregious, which I can't think off the top of my head that's ever happened. But yeah, for us it's the same way. Usually rely on our trauma service at the hospital.
Now, a lot of the literature uses trauma scoring systems, and I know a lot of our trauma databases, in Pennsylvania, it's Pennsylvania Trauma Systems Foundation. You guys, I don't know if it's ACS or something else, but this stuff gets scored. I never see it used at the point of care. Is that unanimous? These are things used for registry purposes and when you're doing research studies, but okay, so I don't see them being used either. So this patient does not go to the OR. By hospital day 3, they're okay for the OR. The femur looks okay, the wound looks okay, he's in an X-fix. Irfan, what do you think about this? Patient goes to the OR for the distal radius. You ever see something like this happen? Not the femur yet, the distal radius though.
No, that's rare. I think usually they would stabilize the long bone, and if they're cleared
Well,
for
it's in an X-fix.
Well, I still think that if they're stable for the OR from where we are, either we would try to do both at the same time, or if one is needed, then it's probably the femur that needs to be fixed. Distal radius can be taken care of. I haven't seen the X-rays, but
From a
week,
practical
2 weeks.
standpoint, let's say this patient's in the hospital. This is a real case. The ortho trauma people are completely backed up and you have a slot, and the resident says, listen, Dr. Ahmed, you want to just get this distal radius done? He's already in the X-fix, and you're in that room. We can't fit the traction table in there. So just get it done?
Yeah, I wouldn't say that's never happened, and I wouldn't say
so-
that's not totally unreasonable, and if the patient's stable to get one at least taken care of. It's not ideal or where you would think if you had a multiple choice question where you would want to proceed
Exactly.
with.
I agree. This is not a textbook sequence, but I'm giving you a real case. This is exactly what happened to this patient, I think, is that the way the day lined up, there was an easy way to get the wrist done that was going to need to get done at some point. It clearly was not necessary at hospital day 3, but the femur could not happen that day. So, no, this is not your black dot answer, but
What was the reason again for the femur not being, it was just people were busy?
honestly, I can't remember. I know this case well. It's not that long ago. It's last year.
Okay.
But, and actually, I didn't fix the distal radius. It wasn't my OR day. But, I think that it was a case that, I think the patient might have been in the OR for gen surg for something else.
Yeah.
So
it happens.
patient was in the OR with gen surg, I believe, and it was an easy setup to get the distal radius done, not necessarily for the femur, because there was another full room going. So, anyhow, I mean, I just wanted to get your take on it. Rakesh, how do you handle head injury issues? So this guy's got a head injury. Is there any literature you want to quote? Is there anything specific at your institution that you guys use to decide? Now, this guy had an open fracture, so there's some immediate issues that night, but then the next day, even during the week, how do you guys handle the head injured patients?
I mean, of course, in terms of acute management of the head injury, clearly we would defer to our neurosurgery colleagues. But in terms of how it relates to the care of the orthopedic trauma patients, I mean, I'm assuming, you're talking about like in terms of
timing. I'm talking about timing. How does that impact, when you guys are trying to decide, let's say if it was a closed femur comes in, polytrauma patient, they have a head injury, like, is there any criteria, or is it simply just whatever the neurosurgeons say, or
I mean, again,
like no-goes that are for sure?
No, I mean, unless the patient's actively, bleeding or actively stroking, as long as the neurosurgery team is comfortable with us going, we'll take them, and we'll even put ream nails. Even acutely. It's just trying to think off the top of my head. We try to get to these sooner rather than later. I mean, unless they're having an acute neurological event, short of that, we tend to be aggressive in terms of getting
what
these
we've
long bones.
seen is a lot of times they're going to get serial CT scans, and
Right.
usually by the time those first couple, maybe it's not serial, maybe it's just a one repeat, but that usually happens over the first 24 hours or so. I mean, I think they usually have some idea where this is heading by then. So, I guess at my center, if this was a closed femur and came in at 6 p.m. with a head injury, we're definitely not nailing it that night.
But would you do it the next day?
So if the lactate was cleared, and that's a good question. So if this guy had a closed femur, would we nail him the next day? Well, in this case, he had some pulmonary issues, but if it was just the head, yeah, I think from a head injury standpoint, we would nail him the next day if his lactate was cleared, and otherwise we felt he was resuscitated. Yeah, I think the only literature I'm aware of is like emergency, like within 2 hours,
Yeah, it's all
nailing
acute.
femurs with head injuries is probably a bad idea. Outside of that, it's like talk to your neurosurgeon.
Right.
All right. So this patient, it's like a Thursday, so this now rolls over to a Monday, I believe, is probably how this evolved. And now patient's been stable. I guess, at least in my center, we kind of feel, if the patient has the X fix, we kind of are at least good for a little while. We don't want the pins getting infected, but we also don't feel like the urgency as much as if a patient's maybe in skeletal traction to get the patient right back to the OR. So what do you guys think? 8 days okay? Let's say, the wrist thing never happened or is going to happen now. You guys all right converting at a week?
I think 8 days is okay. I think 2 weeks is the sort of.
You don't
party
like going
line
past
literature.
2 weeks,
Yeah.
okay?
Well, why retrograde? Or you don't know. I mean,
What's that?
why not integrate now?
Oh, why not? We're not going to get into that.
Okay.
I don't know. Anyhow, separate discussion. Could have been, I guess. This patient, and I'll just say as a side note, X-fixes are not a free lunch. I've seen these sometimes where this guy had a head injury also, so you can chalk it up to that. Very aggressive bone healing response. That's 5 weeks. What you can't really appreciate here is that, some of this HO are like little pillars of bone sticking up through his muscle. If you can kind of recognize he has this HO forming at each of the external fixator pin sites. And these things, they don't look that bad on x-ray, but they're literally like little spikes going through his quads. I've seen this in some femur X-fix patients, occasionally in the pelvis, in polytrauma patients. They get this aggressive HO response. Actually had to take this guy to the OR. Actually had to do a manipulation on him 6 weeks out, and then I had to take him to the OR and resect all that stuff and do like a Jude kind of quadplasty to get his knee moving better. So, X-fixes kind of sound great at the time. they scar down the quads, they cause this HO sometimes, I mean, they get infected, so we gotta be careful.
So if I can ask a question on that
Yes.
too. For HO excision, just take this example. I mean, I've gone back and forth in terms of timing for HO excision. So I just wanted to see what these guys thought. Here, I guess you did it 6 months post-injury, which is sort of the party line. Have you ever done it sooner than that? And if you have, have you ever regretted resecting HO sooner than 6 months?
I've gone.
I have.
All I'll say is I've gone a little earlier than I haven't. I didn't even get a bone scan on him. We just kind of did this.
Mm-hmm.
But you say you have. It's come back on you.
Yeah. I mean, that's just anecdotal. There's no.
We'll
do
see.
you guys exercise HO sooner or later?
I like the 6 month time point.
Right.
I can't say that I waited for 6 months. It just kind of it's just kind of how it played out with this gentleman in particular. So I think that, in my opinion, there's a little bit of a pendulum here. So not too long ago, I mean, we had a concept of early total care, which is that, it was, the patient was too sick to not operate on, is I think how the quote would go. You really had to kind of aggressively stabilize fixed long bone fractures very early. And then I think certainly during my residency, there was the concept that got very popular of damage control orthopedics, in which patient was too sick to operate on, and you shouldn't be doing reamed nailings acutely. And this is the term that has gotten a little bit more popular now, that I would say is a little bit of a swing back of the pendulum to this so-called early appropriate care, and I don't know exactly where we're heading from there. There's a couple of papers from Cleveland where Dr. Valliere has been the lead author and sort of, I guess you could say, popularizing this early appropriate care technique. It's very simple, and what they've shown is that it's a little bit of a swing back to early total care, that, hey, maybe we're ex-fixing too many patients early, maybe everybody doesn't really need a damage control, maybe it's prolonging their care, maybe that guy who got his nail done at 8 days could have been nailed at 3 days, et cetera. So what they really said was that, when you did definitive surgery within 36 hours with these parameters, the patients did well, and they got out of the hospital and mobilized sooner than if you used a damage control approach. Multi-center study, Dr. Bossi is one of our guest faculty, was involved in, also showing that admission lactate and pre-op lactate is important in our assessment. And I would say, and I would ask you guys, at your centers, I mean, are you looking at this more than in the past? Are you, as part of your evaluation, lactate levels? You could just shout yes or no.
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 The trauma guys don't seem to look at lactate where we are.
Okay, Irfan?
No, not as much as I think they should, but I think it's just looking at the overall response and then again deferring to the trauma team, what they say.
Rakesh?
Yeah, same thing. I mean, we probably should, but at Cooper we don't.
Oh, I would say at our center, they've been doing it. I mean, there used to be that I would ask what the lactate level is, and I was told, well, nobody drew it. And I was like, well, that sucks. And then now it seems like, I don't know, maybe we just keep talking about it, or maybe in their mind they think it's important. I seem to always have it when I ask for it. So this is, I think, I want to get your take on this. So this, to me, was really hammered into me, I would say, when I was learning about damage control orthopedics, and this was taught, and this is on all the OIT exams and all the ortho trauma textbook, that you had this second hit window, right? That was between, that first trauma and peaked between 1 and 5 days. And it was sort of like this no-touch time, so that if a patient came in and they're getting resuscitated, and that's all fine, and maybe their lactate clears, but you had this window when you weren't supposed to operate on them, for fear of stimulating a surge response and precipitating ARDS and everything like this. What do you guys think? Where are we with this now? Because this early appropriate care does not really, I don't know, does it really address this? Because if you're saying the lactate's cleared, you can go by 36 hours, you're right in the middle of that window. So how do we reconcile this? Whoever wants to take it.
Well, I guess the term early appropriate care, like what is early, what is appropriate, but if you've ever seen somebody crump after a second hit, it makes you sort of ponder, why did I just do that? And then you find out they're in the vent, in the unit for 2 weeks on the vent. Well, maybe if you waited a couple days, that would be okay, and nobody would. You're trying to figure out. We don't know who those patients are. You're trying to figure it out. And then there's some people who you waited the 5 days, and then boom, they're perfect. Like you got it right. So when you get the ones right, you're happy. When you get the ones wrong, it's devastating.
Oh, we don't,
know.
we learn from experience.
Exactly. So
but-
I think there's more data out there that's helping. Then we're trying to use those surrogate markers for who's ready and who's not ready, whether it's clinical parameters or laboratory.
But I guess I'll ask a simple question. Is this still correct or no? Because if you're saying a patient clears their lactate and is good with 36 hours and you should do early appropriate care, I think that flies in the face of this.
Well, I think that's only one marker of resuscitation, and versus pulmonary status, neurologic status, and urinary output.
And I don't think they're each mutually exclusive. The second hit phenomenon exists in certain, clinical scenarios, but doesn't necessarily mean you still can't continue doing early appropriate care. I think early appropriate care you're right. I agree, it's much different. The thought is different than, just
The timing is different,
damage
too.
control. Timing is different,
It's earlier.
Yeah, rather than, like we were talking earlier before, should you put a femoral nail in versus fixing something,
Because I would say in a damage control approach, you're doing
Down
that
there,
IM
right.
nail here. With the early appropriate care, you're doing the IM nail here. So,
But that graph and the person getting the IM nail, the spike may not be as high depending upon what his other injuries are. That's what I'm saying.
Right.
I don't think you can take that graph and make a generic blanket statement saying this is the rule of orthopedic trauma. I think, I guess each patient would have a graph there, and I guess it's up to you to decide how high that spike goes for that one patient, whether you decide you want to wait versus go.
Okay. Food for thought. All right, so next case, 45-year-old male dirt bike versus auto accident. Also an open femur, so I'm kind of giving you all these open femurs that you kind of need to do something right away, but I still think it's instructive to think about the next step. So open femur, bunch of other stuff, actually including, not so insignificantly, a right traumatic amputation above the knee, so contralateral AKA in the field. Massive blood loss, as you can imagine, from his traumatic AKA and an open femur on the other side. Persistent hypotension on presentation, lactate 6.2. So patient goes to the OR, they clean up the stump. Patient has debridement, external fixation. So question, next steps. So patient came in the middle of the night, next day stabilized, during the day. So now it's hospital day 2. They're okay to go back to the OR. Patient's stable. Hemodynamically stable, resuscitated as far as you can tell, lactate 1.7, patient's awake, extubated. So IM nail now.
This was a dirt bike injury, so we base it on, what is
Dirt bike injury outside on Broad Street, actually,
Okay.
as a matter of fact.
All right. The wound was clean? Clean as in the sense
No,
that
there was glass.
no gross contamination?
All this is glass. So some contamination with, debris. Yeah, it was not, it was not that clean. There was also a slight question about, there was so much going on at the time that maybe the knee washout needed to be looked at again.
Right.
I've been accused of having trust issues, so he goes back for another IND by me with a planned procedure. This guy's got one leg left, and you got to get it right. The amputation rate on his left side is not 0. Wash him out again, get a handle on what's going on in the knee, and then let's take a stress test. Is he going to survive a lesser procedure, and then come back and nail it?
Okay, so I think these are all good thoughts. I think a lot of the stuff you guys are saying were coming to my mind too, that plus I think it was a case also where it was really, it was actually the patient went to the plastics room, and we could have certainly converted and sort of bounced room to room to get the nail done, but I think you're right. It's his only leg. You got to get it right. Do you really want to be bouncing between 2 rooms, and you're not sure if this, you're doing a second look IND, and you have to wash out the knee that you weren't sure if it was really washed out the first time. and a lot going on in the room. So, and the guy had a very narrow canal diameter, which I realized I had to call in a loaner implant to do this that I normally don't keep here. So that's what we did.
So if my
We
question
got
was,
fixed at a week.
in hospital day 2, if the wound was clean, would you nail it then?
So I would say, I think so, yes. But someone's got to like convince me that like this is not a problem. And I'll be honest with you, this is exactly what was running through my head with this case. It's like, wait a second, I know his lactate's good, but how do I know he's not peaking at hospital day 2 from a potential SIRS hit? So I would say, I think yes. I think yes. I think if everything else was okay, we probably could have. Would you guys agree that from a sort of early appropriate care standpoint, maybe he would have been fine to fix? Matt and Rakesh?
Yeah, I think
Yes
so.
or no?
I think, I mean, if the wound was clean and, you know, if you were the one who did the debridement or one of your, you know, I guess, one of your partners who you know, trusted, I suppose, you know, did it, I think you could nail it.
Okay. Case 3, 27-year-old female, unrestrained driver, airbags deployed, intubated on arrival. It's 10 p.m., all right, so here's the vitals. All right, lactate level 13, hemoglobin 14.6. Patient's otherwise hemodynamically stable. A lot of stuff going on, okay? So open femur fractures bilaterally, so I'll point that to your attention. Chest and abdominal injuries, brain injuries, so pretty much everything, okay? Patient's okay for the OR to take care of the open femur fractures. What are you thinking, Rakesh? Anything complicated here, or is this kind of like our first case? A lot going on, and
Yeah, I mean, the patient's clearly.
you would take
know,
them to the OR,
Clearly,
fix an ID.
yeah, I mean, clearly patient's an extremis, so yeah, I think, you know, washout and bilateral X-fix should be okay.
Okay. So, you know, and that's what you got, you know, sort of middle third bilateral femur fractures, chest injuries. So the patient gets that done. Right thigh wound is closed. Left side gets negative pressure wound therapy. So now what's your timing? And I got some other questions there for you too. Patient's got bilateral injuries. Actually, let's, you know, we've talked a lot about timing. Obviously, it's the topic of the session, but what do you guys think about filters? It's a good question. Patient's got foot injuries, C-spine injury, well, it's non-op C-spine, and pelvic injuries, bilateral femur fractures, and a head injury.
The liver also will
And
slow
there's-
down your anticoagulation.
Yes. So a lot of considerations. Is this the case, Irfan, at your center, is this something you see might get a filter?
Yeah, we actually try to push more for a filter, and I mean, we have quite a robust tumor service as well, and when they are dealing with certain, they try to push for filter more than not. They actually get pushbacks, and whenever we do review a PE, the first question is, why didn't they get a filter? I know filter's not without their complications, but our threshold is, you know, if there's a doubt, we usually ask or request, or at least say that patient should probably get a filter.
Let me
And
ask
this
you guys,
patient, yes.
yes or no, do you guys think
Yes.
that this pendulum has swung too far away from not using filters? Meaning, like, do you think they should be used more than they are now, yes or no?
I think they should be used thoughtfully. I don't-
But
at
more,
least-
do you think that we've gone away from them too much, yes or no?
Yes.
I think so. I think in our.
Matt?
Where I am, I think it's sort of just right. I mean, do I have to sometimes fight for one? I guess so, but I don't see a lot.
Because I think this is a good case for this. I think we kind of have, maybe. I think that, yes, we're probably doing too many filters. I would see patients in my clinic who I would realize had a filter in, and I was like, oh, wait a second, you have a filter, and I'm the only doctor you're seeing now, you know, a month out, because everybody else is done with them. I was like, maybe we need to get that out. I wonder how many patients I didn't even think about telling them, all right, because they don't have a follow-up with radiology. Filters were getting left in, probably thrombogenic and caused problems. So, but I think I have seen patients that I think could have had filters and didn't, and I think it's just not something that people are thinking about anymore. I don't think that discussion comes up. So, this patient goes to the OR, is X-fixed, goes to the OR 1 week later, X-fixed removal, still negative pressure wound therapy on the left thigh, gets extubated post-op day 2, head injury is getting better. Dr. Craig, what do you think?
Well, he set me up. That's my case. She did all right. Everyone was surprised. She ended up getting presented at a meeting 3 months after the event because of her high ISS. And I said, oh, I just saw her yesterday. She walked in. She was, holding her baby. She's 27. We kind of also left out the fact that she was a heroin addict, but came in clean. I think the timing was good. Neurosurgery was a little challenging to get to yes in terms of her timing, but I like the 5-day point, and we fixed her at 7 days, I think, 6 or 7 days. And then it's also a conversation with the trauma team, with the anesthesia team, and my opinion, the orthopedic doctor doing the procedure. This is what we're going to do. Here's my plan. We're going to also, with bilateral femur fractures, we're going to fix one and see how you do. Okay, if she crumps after one, fine, let's get out of here. We did one at a time. We prepped and draped one leg, fixed one leg, and then we paused and sort of have another little huddle and say, okay, is she going to survive another femur fracture nailing? If not, we keep the X-fix on and come back for another day. So we kind of had a whole plan.
So do you guys,
care.
or maybe I'll just ask Rakesh, do you take the same approach? So let's say it was a damage control case, but you got both femurs. Do you say, let's plan to nail both as long as things are going well, or do you definitively say, I don't like nailing both at the same time no matter what? We're going to come back 2 days later.
I mean, I guess you just see how the case is going.
Okay.
I mean,
So you tell them, like, we might get both done.
Right. I mean,
Okay.
you plan for both, you accept one, hope for two.
Okay. It's a good question. I mean, I think nailing both femurs at the same time is a consideration. It's one of the things you think about when you decide, is this a so-called, borderline patient to go down a damage control route? So I think it's a good discussion. So this is not that case. So this is an audience response, again, for your clickers. So you have a polytrauma patient with a femur fracture, okay? Lactate is normalized after 36 hours, okay? So they come in, lactate's 5, and now it's 1.2. But they're still like 90s over 60s all night long. They're making good urine. The hemoglobin's okay. They're not tachycardic, so it doesn't seem like an all-out obvious shock picture. And it's 36 hours later. So what are you going to do with their femur fracture? So let's give a countdown. So select your answer. Wait another day. They're in skeletal traction. Try again for tomorrow. Go ahead with an X-fix or proceed with IM nailing. So again, small portion of the audience actually answering questions, but for those who answered, what do you guys think? So it looks like people are saying proceed with IM nailing, but some people want to wait another day. What would you guys do? This is actually this is a case I had last week. So patient, I was like, where's the lactate? And they said, well, here it is. We always have it for you now. And it was normalized, so 90s over 50s, all night long.
The lactate thing is you're treating lab tests, not the patient. So I think it's one picture that helps you. Then there's the other patient who's completely normal.
But this patient,
who's completely, blood pressure's okay, and the lactate's still high. They're making urine, they're good, everything's fine, they're awake, they're alert, they're talking to you. The pulmonary status is fine, and their lactate's still high. Then what do you do?
Well, what are you going to do for this patient?
I said wait another day.
Wait another day.
I want to know
Okay.
why they're hypotensive. Anesthesia is going to make them hypotensive more before you even touch them from an orthopedic standpoint.
What do you guys think? What's your answer? 1, 2, or 3?
I probably wouldn't nail him. Maybe either 1 or 2.
So it's not 3. Okay. We did 2. And the guy was still intubated. That wasn't really the issue. It was really just that, I think we put a lot of faith in like looking at a lot of these parameters, but if someone's hypotensive, they're hypotensive, and maybe just something's not adding up. So yeah, the ICU attending and I kind of agreed maybe we shouldn't nail him, but we didn't know when this hypertension was going to get better. So you could wait another day in skeletal traction, I guess, but we thought if this is going to continue, maybe we should X-fix him. So that's what we did. So different case, just to kind of show how these things can go sometimes. 56-year-old male, status post fall from a ladder, 5 feet. So cinder block fell on top of him. So a little bit of abdominal injury, pelvic injury, no fractures, but open femur fracture with vascular injury, multilig knee injury, and some other stuff, and not the healthiest patient. 56-year-old male, diabetes, hyperlipidemia, lactates elevated on admission. So the patient goes to the OR, gets a vascular repair, gets a spanning X-fix, antibiotic beads, thigh fasciotomy. How concerned are you? How concerned are you, Irfan? Look at this now.
So yeah, I think this would
Hospital
be,
day 1.
yeah, this is definitely, I mean, if it wasn't for the vascular injury, this guy meets the thing where you would probably do damage control, not try to do an IM nail, just wash it and X-fix it. And I think you have to, the curve which you showed, I would definitely wait at least day 5 on this. You have to look at, you sometimes call endpoints of resuscitation, or see if a patient is responding to your resuscitation. And if they're not responding at all, then they're probably not the best candidate to take to the OR. And if they are responding, then you have to look at what the reserves are, how young they are, and you can maybe trial. This guy, he's 54, but he has a lot of other issues. So I would wait till he's pristine before proceeding to the OR.
So he stabilizes a little bit to at least get him to the OR to do a second look. Gets that done. Antibiotic beads are exchanged. Hospital day 3. What's going on? I mean, I'm not going to belabor the point here, but the point is, sometimes you have young, healthy trauma patients, and then sometimes you have trauma patients that have a lot more going on with vascular injury that's not going so well. This guy had a clotted repair, and this was a fatal injury for this patient, actually. So, open femur fractures are no joke, I guess, is the way I would put it. So I think,
Well, vascular injury, the tibia, I think, is 50-50. I can't remember if it's also includes femur, but you have a 3C, it's a 50-50 shot that you're going to save the leg.
yeah. Well, if this guy died, I'm
Yeah.
not even saving his leg. I mean, this guy died. I mean, we're not going to have an M&M conference here,
So-
but I kind of wanted to point this out.
Well, some people would argue, why save the leg? Maybe
Right,
that's going to be
well, yeah,
discussed
exactly.
with Dr. Bossy
Right.
tomorrow.
So, in an M&M conference, you'd be talking about, like, should this patient have had something else done? And I'm leaving out a lot of details, and I don't remember a lot of details with this particular patient. But I think it's just worth saying, open femur fractures are bad actors. I really don't like the ED washout for the open femur fracture patient that we kind of started the session off with. And I'm glad you guys kind of shot that down, right? Okay. Because, the patients can bleed out. Anyway, so another audience response question. You have a polytrauma patient, multiple gunshot injuries. Obviously, he's one of our patients. Left distal femur shaft fracture, right tibia fracture. It's been 36 hours. I keep saying 36 hours because, again, early appropriate care, right? So a lot of the data that's, I think, where we're at in 2019, right? Which is maybe we were doing too much early total care. Maybe then we were doing too much damage control, X-fixing everybody. We can probably fix a lot of these patients within 36 hours with definitive treatment, right? So it's 36 hours. Its lactate is normalized, making good urines, hemoglobin's okay. Guy's tachycardic in the 140s. He's not hypotensive, he's just tacking away. 140s, 150s. This is a guy actually I had to treat on Monday.
And how old is he?
Audience response, let's give a countdown before we get our panel
Do we
to
know
chime
the
in.
etiology of the tachycardia?
No, he's just tachycardic. He's in the unit and he's just tacking away. And they're just like,
Young guy?
just tachycardic. Young guy, multiple gunshot injuries. 10, let's get our countdown. So young guy, tachycardic, they're giving him IV fluids. Maybe he got a little bit of blood. I'm not entirely sure, to be honest with you. So what do you do? So audience says we're gonna, so pretty big spread, I would say. But a lot of people want to fix this, but some people think, you could either wait or I am nailing. So go down the panel here, Rakesh.
Well, just process of elimination, that you, either 2 or 3. I mean, I don't
Okay.
think I would, I would try to at least get to one of the long bones. I mean, I guess the same thing, you'd see how, I'd start with the femur,
Okay.
and then keep working until,
So you want to do something. You don't want to wait another day in traction.
no.
Okay, Irfan?
So
What
I
do you
was
think?
saying, if this is a youngish guy, his heart rate's in the 140s, and that's maintaining his lactate and urine output and everything, and that's pushing it. But I think taking him to the OR might push him or her over the edge. I don't think I would nail anything right now, so not 3 or 4. I don't see huge issue in waiting another day, especially it's the 3-day window, and if you go the hit of the anesthesia plus everything else, so I think I would probably wait another day.
So Matt, let me ask you a slightly separate question. If the patient wasn't tachycardic, would you proceed with IM nailing of the femur and tibia?
Yes.
Okay.
Blood pressure okay, young guy, GSWs, they're not technically open fractures, we say. So,
Okay.
And then.
So that would be the early appropriate care. I mean, that was the
Yeah.
plan with this guy. So this guy was on for IM nailing the femur and the tibia, but, he was tachycardic in 140s, and like, it was the same discussion, me and the ICU attending, like, so we X-fixed the guy. And then brought him back, not in a week, within a week. I think he got X-fixed on a Sunday, and I fixed him on a Wednesday or something like that. I mean, he proved himself to be stabilized totally fine, and we didn't feel the need to wait, and then we did fix both. All right, so we're getting closer to the end, so we'll try to get through a little bit more, and then we'll wrap it up. So case 5, 29-year-old female, slightly different injury here. I mean, a lot of open femurs, but we'll just say polytrauma, a lot going on, right? Chest injury, proximal femur fracture, liver lac, head injuries, so all kinds of stuff going on. So hospital course, patient comes in, lactate's 3.4, trends down. And this case is, I don't remember the details, it's too long, this is a few years ago, but I had good pictures on it, so I had it tucked away somewhere, so I pulled it back out again for this discussion. I'm going to just say there were some major chest problems going on with this patient. Maybe it was a flail chest. Surgery has been asking us to hold off. So what's your next step? When do you end up doing something like some kind of X-fix or something like that for a proximal femur?
I'd have to
Matt,
say.
what do you think?
I've
So if it's
never-
a perichoke fracture, are you saying, let's take it and X-fix it because you're not going to let us do anything else, or are you kind of sitting on that?
I'd want to have a conversation with C2. What are we waiting for? They say, oh,
They're
you gotta
not
wait,
letting
you
you
gotta wait.
go.
Well, I know, but what are we waiting for? Well, what is it that they are looking at to say you can't go yet? Well, what is it? Is it blood pressure? Is it heart rate? What is the marker for its go time versus you have to wait?
Okay.
And what's going to change from day to day that today's no and tomorrow's yes?
Okay.
And a lot of times it's just like, I just don't feel comfortable. I'm like, well, this patient is also with a bad femur fracture and it needs to be taken care of. I wouldn't want, on a X-fixing that proximal femur, I would just leave her in traction. But
What do you guys think, Rakesh?
Yeah, I mean.
So
the
I guess my one
X-fix-
question is like proximal femur fracture, like when you now have everything else we've talked about, are you just saying, oh, it's a femur, so if I have to stabilize it, I can X-fix it, or are you more likely to kind of maybe sit on it?
I mean, I think X-fixing proximal femur fractures are problematic. I mean, I think that's, I mean, you can obviously do it. I mean, that actually doesn't look that bad. I mean, it looks pretty good, but I don't think you can be faulted for leaving it in. Do we have an X-ray in traction?
I don't know if I have it here.
I mean, if the X-ray in traction is poor and it's,
I mean, I don't think that the lateral was, I don't know what it looks like in the X-fix, to be honest with you, in the lateral, but, so.
but I mean, I agree with what Matt said. I mean, this is a discussion. I mean, what are we waiting for, and what are the parameters to say, good is good enough?
Yeah, I mean, I think some of the stuff you guys brought up before is good because I think, you know, a lot of times it comes in on the weekend, you have one team taking care of it, you come in on Monday, the ICU attending's like, I'm just seeing this patient for the first time, and a lot of times at academic centers, information flows like, kind of like, you know, down to residents and then back up, and you have like an ED intern carrying the trauma pager or something like that, and it's like, I think that, I think what a lot of us have learned is that, you know, not that the residents don't know what they're doing, they know better about some things than we do, but I think that the consistency tends to be, you know, the attendings for the most part, although even though SICU attendings changed, you know, they have no problem if I call the person who was on that weekend and say, listen, I'm dealing with this now, what was your thought on the weekend? And you know who to reach, and we've dealt with it before. You've had this discussion 5 times before with the same people. So I think we've learned that you got to have some attending to attending discussion, and it's an ongoing thing that happens, hopefully, as you have a working relationship with these people. Like, what is it? Maybe this case got kicked down the line when it really didn't need to be, right? Maybe what Matt jumped out right out saying, like, well, why are they telling us to hold off? Well, maybe just someone casually kind of said that, and that got filtered down to the intern and told our intern, and now we're just getting told patient's not cleared. Well, maybe if you talk to the CT attending, like, oh, that's what you're going to do? Patients should be okay.
Well, they say, oh, I thought it was just one of these hip fractures that you guys, like, you know, do whenever. You know, like they thought it was a
Right.
hip fracture. Oh,
Right.
somebody told me it was a hip fracture, like it was an 85-year-old white female who fell from standing height.
Yeah.
No, this is not a hip fracture, quote unquote hip fracture. This is a high energy proximal femur fracture in a young person. This is different. So that's the cell they got. Oh, there's some hip fracture lady. Do we have to do this now? No, these guys wait. It's okay. And
Yeah.
they get the messages wrong.
I think, you know, some of the other issues in the proximal femur are, you know, the X-fixes are awkward. We do them. I mean, I think I had to do one a week ago or something like that, and a patient that we really were not going to be able to fix at all, and still haven't actually. But they get, you know, you're in a lot of soft tissue up there. The pins drain a lot. They get potentially infected, and you can sort of burn some bridges. So I would argue, and I think some of you guys are saying, maybe the timing in this case could have been improved, perhaps with better communication, if there could have been some clear understanding as to what exactly was holding this patient back from going. Maybe some issues could have been addressed. Maybe, you know, if you have a fracture that's not even X-fixable, you might have to have a discussion. You know, the trauma team might be thinking, oh, why can't you X-fix it? And they're not cleared, they have to get an X-fix. And you're like, I can't even X-fix this fracture, it's an intra-articular whatever. Or it's something like, an intertroch or something, I think is a good example. I mean, you don't want to have to X-fix an intertroch. So anyhow, that's what happened with that patient. I'm going to, for the sake of time, skip this last case because I think it's more the same. I think this case really was just illustrating the point, what if you have multiple injuries? You have a pelvis, you have a femur, you have a lot of stuff that you have to fix, you have upper extremity fractures. I think what we've learned is that, yes, you can, like what we're doing with early total care, fixing everybody right when they came in, you can stabilize them relatively quickly, and it seems like you can fix all those injuries. Again, it's a logistical thing sometimes, how much OR time you have, do you have all the expertise? If it's a nasty, distal radius and you really need Irfan in the room, is he there for you? But if that all that lines up, the practical stuff, are the patients safe to get all this stuff fixed once they're stabilized after 36 hours? The answer is like, probably yes. It's a case-by-case thing, but I don't think we have to, I don't think the pendulum is as far back as it was with damage control, which is like you were waiting on everything. These slides are hard to follow. I'm not going to try to take you through them, but I think I just want to make the point that this is a real debate in our community, I think. I thought it was an interesting session to start the meeting off with. I know a lot of you may not be involved with a lot of this decision-making that we see at the trauma centers and the ICUs and stuff like that, but to me, surgical timing is like, it's a question we have all the time. And it's a question we have with our colleagues who were taking call with us, like, is it appropriate timing to fix this fracture? Should we wait? I mean, and it's like, I feel like we are still trying to figure this out. In some of the European journals, like Injury, which I've pulled a couple of these again, I'm not going to try to take you through them, but they're really trying to wrap their heads around, like, what's the right approach. We were big proponents of damage control, certainly in the European literature, injury journal in particular. Now they're recognizing early appropriate care maybe is the way to go, and they're trying to find, like, what's the definitive pathway protocol. They're coming up with new acronyms now that I'll spare you, but if you're interested, you could certainly look this stuff up. If I have time, I'll post some of the papers on the OrthoClips webpage for this. But I think I think it still comes down to, like, understanding the literature, where we are now, communicating, attending to attending, and hopefully, just learning from each other at sessions like this. So I want to thank our panel for coming in and lending their expertise. I think it was really helpful. So thanks.